Let me share my screen. All right. So good morning and thank you for joining us for our business meeting. This meeting is being recorded. Documents which will be discussed here today are available on our event calendar on our website, which is wnc.wa.gov. I am Amelia Boyd and I am the program manager for the Medical Commission. Kayla Bryson and I are the organizers for this meeting. Please be sure to mute yourself if you are not speaking. The commissioners as well as WNC staff will be responsible for muting themselves when necessary during this meeting. For those of you joining us via the GoToWebinar platform, the chat function and the questions box is available. Please note that anything posted to the chat or the questions box is considered public record. We will take public comment at this meeting. It is item 7 on the agenda. Once we get to that item, the chair, Mr. Malden, will read a script and will then ask for public comment. If you would like to make a comment, please use the raise your hand feature or simply speak up if you are calling in. Our time for public comment is limited and each speaker is likely to only have about 2 minutes to speak. If you have questions or comments, please send them to me at amelia.boyd@wnc.wa.gov. And then just a reminder, we have an addition to the agenda this morning. We are adding the transmission of time-critical medical information to the policy committee agenda. And with that, I will hand it over to Mr. Malden for his chair report.
So that's a little out of order, but I got to do it anyway. So just a couple of things. Start off with a pleasantry. I had a opportunity to see Dr. Harry Harrison a couple weeks ago. We had a pleasant conversation. He was in town doing some consulting work for Kaiser. He said he asked me to say aloha to all of you. So really good to see him. The executive committee has decided that meetings will continue to be virtual through the first quarter of next year and likely in the second quarter, but it's too early to make that call. So we'll continue with this format, which is never very much fun, but works. I am doing some outreach work as the chair. I've had 2 meetings with HCA in the last couple of weeks, one to talk about telehealth and telemedicine, and then one was a meet and greet, talking about visions and goals and so forth among our respective organizations. And I'm hoping to do a little more of that throughout DOH in the near future. In the early part of December, I have a meeting scheduled with the WSMA executive committee, and I hope they are going to be nice to me. Poor Dr. Roberts had to defend himself in the commission the last time we got together. Hopefully it will go a little bit better this next time. I hope you all had a chance to read my email on case assessments. I just want to make a couple of comments about how important the case assessments are to the work that we do. Just remember that every case that we open has a significant impact on the licensee's life and livelihood. So documenting our files is extremely important so that there's the opportunity for a long-lasting document that provides an analysis and the rationale behind our decision making. I also want to bring up at this time, some of you may have noticed that there's some new language on the assessment form where it talks about not mentioning the respondent's gender, age, location of practice, or whether foreign trained or not. That document resulted in one of our commissioners, and along the email discussion I had with that individual recently, this individual asked that the entire commission have an opportunity to discuss this issue, and I don't know if that particular commissioner is on line or not, because I can't see all of the pictures. But if you are, would you like to start off a conversation about the new language on the assessment form?
Hi, it's Charlotte. Can you hear me?
Yes.
Great. So, yeah, so my concern was that by having this blanket statement, it's actually telling us the information that we can't present, even if it could be relevant, and that it's actually telling us that implicitly we are biased in what we say, when in reality, oftentimes that information is relevant. And I think that rather than making a statement prohibiting us from saying certain things, that we should have the discretion as commissioners to be able to determine what is relevant, and to be able to be thoughtful ourselves of whether or not what we're saying has the potential for bias, and that fellow commissioners should feel free to question whether or not the information that what we're presenting is biased, or how it is relevant, but that to have someone else other than commission members tell us what is relevant, and to imply that what we present represents bias isn't appropriate. As physicians, we and other healthcare providers, PAs, that information oftentimes is relevant, and to prohibit us from saying it is actually inappropriate. And as I said to John, I felt insulting, because it implies that we don't know how to recognize bias in ourselves and work together as an organization to figure out what information should be transmitted, and what information we should reflect upon and determine whether or not it's bias.
So before anyone else makes a comment about the language, Melanie, could you give us just a very brief overview of how the language came about?
Yes, thank you. I'm assuming you can hear me. A nod?
I can.
I can hear you.
Thank you. Yes, we have been trying for many years to sort out any type of implicit bias that any of the processes that the staff does or that the commissioners do that might introduce that unconsciously into the decision-making process. We started this journey in about 2015 when we brought in trainers to train the commissioners in implicit bias. Those of you that were at the November 2015 meeting might remember that training. We also had a training this summer that y'all attended. I think it was August, perhaps. This past November of 2019, we invited a group from the Office of Equality, from the Department of Health, to sit through a commission meeting and a CMT to determine whether or not there was anything that we could do, or that we were unconsciously introducing bias into the decision-making process. And they came away with some recommendations and some findings. And basically what they said is they had heard a lot of commissioners introduce cases with the respondents' age, their gender, and where they worked, and that was one of the things that could introduce unconscious bias. Obviously, we don't believe, or they don't believe, that commissioners or anybody is introducing bias consciously, but we all have, unconscious bias, and so we're trying to scrub that out. In the summer of this past year, June of 2020 and July, the executive committee took a stand on racism and published a statement in the newsletter saying that racism in any shape or form was a public health issue. and we vowed to ensure that what we did as an exec committee would not, we would ferret out anything that we thought was introducing any kind of bias into the processes. And we then vowed to look at every process we did internally with the staff and with the commission to determine if any of those things introduce bias. One of the things that we did internally was to change the way we recruit employees. So that is all done blind. We redact employee resumes and whatnot. So the hiring committee, the first set of interviews is done blindly. So then we looked at our CM assessment form, and we put a statement saying, please do not, when you are making a case review discussion or presentation, state the respondent's age, whether they are foreign trained, where their location is, and their gender. I don't think it's a restriction. I believe it says, it's up to the commissioner if it is relevant to the discussion, but we are trying to make sure that even unconsciously, you are not introducing bias into the decisions. So that is the reason why that is on the form now. And please, if you have any questions, I would be happy to answer them.
So Melanie, I do have a couple of questions. And the first one is, how many of those observers were actually physicians or PAs? And
0.
Okay. And so I would say that actually this is something that physicians should be weighing in on, and physicians assistants should be weighing in on, and commission members as a whole. And secondly, why not just say, please only include that information if you consider it to be relevant? Why say don't include it?
I don't think there's any reason why we put don't as opposed to please, only. Obviously, we can change that wording if that is something that y'all want us to do. We are evolving. So this wording isn't set in stone. Again, we just started doing this, and so we are always in continuous process improvement. So if you have a better way you would like to state that, that's perfectly fine.
Well, honestly, it should have come to the commission as something that we all had input on before that statement was placed there.
We change our forms quite a lot without. We actually had a group look at the assessment form prior, and that included commissioners, but I don't know if a group saw this particular wording.
I think what's important, and I pointed this out to Charlotte before, that I think just to mention those 4 things is not a material fact. But if one of those 4 items is a material fact in the case that you're reviewing and as part of your analysis, then it needs to be mentioned. So a couple of examples that I used in communicating with Charlotte was a geographic area, so that if someone is practicing in a very rural area, it's okay to say, give a description of the geographic area. And it is a material fact because the standard of care in a very rural area is different than an urban area. But you don't necessarily need to say what city it is or what the facility or the facility in which the incident may have occurred. Another one we talked about, or I talked about, I should say, is age. And this might be an extreme example, but if a respondent has age-related dementia, and it's an age-related dementia, or dementia was a material fact in the review of the case, then certainly that is something that needs to be mentioned. Should not be absolutely prohibited, but if it's a material fact to the analysis, it needs to be stated. Dr. Curry?
Can I just say something? Thank you, Mr. Malden. I applaud the Commission's attempt to scrub our forms and our processes to make certain that we are all aware of the potential implicit bias involved in these things. I think it is something that's important to do. And maybe not to belabor this, could I just suggest that I'm looking at the form right now, And it just says, when filling out this form, please do not include information about respondent's gender, age, location of practice, or whether the respondent is foreign trained. Could we just add, unless it's relevant to your analysis? Just add on a few words there to sort of couch this in the spirit that it's meant to be taken in. But I just want to say I do applaud the commission for doing this work. Thanks.
Certainly, that is easy to do.
Comments from others?
So this is Bob. I don't know if you can see my hand up or not. For some reason, I don't have the little hand function showing up on my screen here, but I just want to say I do agree with everything that Charlotte has said. That may not be a majority opinion. I may be in somewhat of a quote unquote unique position in that as a psychiatrist from day one of training, we are trained in the old psychoanalytic concepts of transference and countertransference, and to recognize our unconscious biases and how they impact our assessments of patients and how we interact with patients. I would like to think that we are all mature enough at this stage in our lives that we can make reasonable judgments about when these types of information are relevant to a case and when they're not. But I do agree that the statement as written is a blanket dictate to not include any of that information, and it can be relevant. I agree with Diane's suggestion about how to modify it.
Thank you, Bob. I think Dr. Chung had his hand up.
Yeah, thank you. I just wanted to say a couple things. One is I do agree with Dr. Curry's suggestion, but I also wanted to make a comment about implicit bias, which is I think it's maybe I may be the minority here, but the assumption that physicians can tell if they're being biased or not, I think is probably not wise to assume. I think studies that have been done in implicit bias would tell you that we are not experts in being able to tell if there is bias or not, or if we're being biased or not, any more than a pilot can be expected to know how to build an airplane. I don't think just because we're physicians and well trained that we can make that assumption. So I sort of see this in the same light as doing a timeout in the OR. When the timeout was first developed and the WHO form was being distributed, a lot of surgeons said, this is stupid. I mean, we know all this. We know how to be safe. We know how to avoid errors. Why are they telling us to do this and giving us a checklist? Well, it turns out that we don't know how to avoid errors, and there are things in high reliability where certain things that are established in the system can actually help people prevent errors and prevent variation that could lead to errors. And I think I see this as one of those situations where something that is established into the system and built in is a good reminder for us to help us avoid the implicit bias that we can't control ourselves. And if you think that you can control it, then I would suggest you do some studies into the topic and take some of the tests that are available and see how good you can actually recognize your own bias, and you'll be very surprised.
I just want to make one last comment, and that is to say, I am certainly not opposed to us examining our own biases. My opposition is being told by people who are not physicians, who are not PAs, who are not members of the commission, that we cannot say certain things because it's suspect for bias. What I suggested in my emails, and the richness of that unfortunately isn't available to all of us right now, is that we should say what we believe is relevant without that being dictated or censored by others. And if others want to call out, as oftentimes happens in the OR with going through these checklists and say, you know, I think that that wasn't a necessary thing to say, and I'd like for us to consider why you said it, or I want to express concerns about bias, then that should be part of our learning process and part of the discussion that goes on. We're better when we talk about these things, as you know, Jemmy, from what happens in ORs. We're better when we all have a chance to weigh in, as opposed to when those on high are telling us what we need to do. That doesn't work well in a hospital. It doesn't work well in an OR. And I found it to be offensive. And that's why I brought it up.
Thank you, everyone. Any other comments? I can't see everybody on the screen, so.
Jim Anderson has his hand up.
Oh,
Thank
okay.
Sorry, actually, I had both my hands up and my elbows too. I was looked like a dance. This is a really rich topic and something that is near and dear to me as far as a PA, a physician assistant who has cared about this for a long time and has tried to educate myself. I get I think I get the issues and the tensions here. And with that noted, I just want to say that I strongly applaud the commission staff's efforts to introduce this topic into our presentations. I've long sort of had some of these same concerns, and so, you know, whether it's must not or don't unless you think there's a good reason, I just think I do think that I mean, I take no offense from non-physicians and non-physician assistants introducing this topic, and to me, I think that's one of the wonderful things about having the amazing support we have from our staff leaders. So it doesn't seem to me there's too big of a gap between exactly what this should say, and it seems to me that we could figure it out very, very easily to provide some room. And I just would really want to agree with Diana and with Jimmy that if we think that, oh, we know when we have implicit bias, I mean, we don't, because humans don't. So that's the way that's part of the burden of being a human. So I support this effort, and I'm glad to see it arise. Thank you.
Thank you. Other comments? Yangling? I think you're still muted. While Dr. Yu is trying to unmute, anybody else have a comment? Claire? Are we having audio difficulties all the way around? Can anybody hear me?
Yes, I can hear you.
you.
Can you hear me,
Yes.
John?
Yes, I can, Claire.
Yeah, in some ways, I don't have trouble with someone outside our group setting up some standards around implicit bias. In some ways, I think that physicians and PAs, we have some implicit bias for anyone not a physician, that we have trouble listening to anyone who's not a physician. And I think the nature of implicit bias is that someone other than ourselves may need to point it out. So I don't have trouble with us not being part of the design and that, but I certainly don't mind also having commissioner input to it. So, but I think there's something implicit in implicit bias that makes PAs and physicians a little biased against someone who's not. That's my comment.
Thank you. Dr. Yu?
It looks like she's trying to call in.
Oh, okay. Anyone else have a comment while we're waiting?
I'll just say one more thing. I am there about implicit bias, and I very much welcome these efforts. My problem is when it's not part of our discussion as commissioners, and when we don't have a chance to enrich ourselves by discussing it among ourselves and deciding ourselves and learning from one another that something may be biased. Just like the example that Jimmy used, we all learn from one another when we're doing it in real time. All I would ask, and I'm sorry this kind of got a little bit off track, is just say on the form, please include that information that you believe to be relevant. And then staff, anyone in the room, everyone should have a chance to weigh in and say, hey, I don't know that that was really relevant. Can we talk about it? And I think we should have the opportunity to do that and learn from one another. That was my only point in bringing this up. It's not that I'm opposed to implicit bias discussions. It's not that I'm opposed to outside folks. However, I do think that people that are not physicians or PAs don't necessarily understand that some things we bring up may not be attractive to those outside, may seem biased, but when we discuss it, it perhaps has meaning to the discussion in a way that others aren't going to appreciate. That's all I'm saying. I welcome input. I welcome attention to bias. I just don't want it to be a blanket statement.
Dr. Yu, are you now connected?
Yes, I'm calling on the phone. Thanks for waiting for me. Finally, I have to say, just from logistic part, technical part, I found when I wrote it up a review, I found that sometimes it's awkward. Just keep repeating, respondent. So that's a little nuisance, but that's beside the point. I can see the point from both sides. I feel the commission, sometimes I learn a lot from commissions at the discussions at our panel, that people have a different perspective and we learn from each other. So I think if I agree with Dr. Curry's suggestion that we can say we would, we recommend, but if help to present the case, the give RCM and the attorney the discretion to still present case with the she or he. And also another point, that is what I think, that's Charlotte's point of view. And the other thing I think, we have this Me Too in a moment. A lot of female patients and female, sexual harassment or assault victims have it difficult to convince the case. And maybe this is not really related to whether, you have to say he or he. But I think sometimes it may lend the credibility to say the perpetrator is, in the nature of the case. And they increase credibility to help the victim to prove their case. But this may not be often and may not have to be that way, but I think it should give the RCM and staff attorney discretion. That's just my point. Thanks.
Thank you. Last call. Okay, I guess if we can have staff take a look at the wording and make some suggestions, that would be an appropriate thing to do. So I assume, Melanie, you will take the lead. Thank you. That's the end of the chair report. We have 2 items on the consent agenda: approval of the August 21st business meeting minutes and approval of the November 13th, 2020 business meeting agenda. Are there other items for the consent agenda that I'm not aware of?
We just need to make sure that we approve the amended agenda for today because we added that
Okay, the
transmission. Yeah.
amended agenda for November 13th. Do I have a motion?
So move.
Second, I have a second. All in favor of adopting the consent agenda, raise your hand, say aye.
Aye.
Opposed? Motion carries. We now have a presentation by AAG Heather Carter on the Open Public Meeting Act. And Heather, I think I saw you
I'm
earlier.
here.
Oh,
Yep.
there you are in the corner. Okay.
Yep, I'm here.
Take it away.
Yeah, so I'm just going to do a quick, probably 10-minute little refresher. Try to do this every year on the Open Public Meetings Act, just because it's something good to do. Also, you're required to have training when you come on board the commission, and then you're required to have refresher training too. So we try and take care of that for everyone since you're all staggered. But basically, the Open Public Meetings Act is a state law that was enacted in the 70s. It's part of a bunch of open government laws so that citizens can see government at work and see decisions being made. So it applies to any multi-member body that is created in statute. So you guys are a multi-member body that has to comply with the law. It applies to state government as well as like local government, so your city councils, that sort of thing too. But it doesn't apply to, say, the Secretary of Health as a single head of an agency. It's just these multi-member bodies. Basically, it says that anytime you have a meeting, which is a quorum of your body, and for you, it's 11. So anytime there's 11 or more of you together, those meetings have to be open to the public, and they have to be given notice that you're going to have the meeting. It can also, some things to look out for is even if there isn't a quorum present, if there's serial meetings that go on, say you have small group to make a decision, that can also be seen as a meeting that could violate the act. The other thing to be careful of is subcommittees. So sometimes some subcommittees need to be open to the public if they're going to be making decisions on behalf of the whole commission, or if they're going to be taking public comment or conducting hearings. So those will need to be open as well. And one other thing to watch out for is emails. Emails can constitute a meeting. So anytime, and staff is really good about this, but reply all can be a problem if the whole commission is on an email string and starts to have a discussion. That could violate the act as well. One thing to note is you can gather together for social functions. I know we haven't been able to do it this year, but you know, at lunch or, you know, after hours, you may have dinner and there's a quorum present. That is okay as long as you don't discuss commission business. So just if there's something before the commission, you would want to make sure that you're not discussing that so that you don't violate the act. So your staff takes care of all the notice requirements. Basically, all your regular meetings are scheduled a year in advance and filed with the code revisor. It's a state agency. You also have some special meetings, and I know with COVID, we've had to do that quite a bit. A special meeting can be called with just 24 hours notice. So we do have to do that sometimes if an issue comes up that needs to be dealt with before a regular meeting. Really, besides the note time for notice, the one big difference with a regular meeting and a special meeting is a regular meeting, which you're having today, you can amend the agenda the day of, and you can discuss things off the agenda. So in a special meeting, because there's only 24 hours notice, you have to stick to the agenda. So sometimes if you have a special meeting and we try and bring up a new topic, we'll say we'll have to hold off on that because you have to stick to that agenda. So there are times when you can close your meeting during a public meeting. Sometimes we've had to go into executive session. The law is very specific about what purposes you can exclude the public for. Generally with the Medical Commission, it has been to discuss litigation or potential litigation. Sometimes if there's public employee issues, evaluating a candidate for when we hired Melanie, we would go into executive session to look at resumes and discuss employees. So those are probably the two most common for your commission. There are things that aren't subject to the Open Public Meetings Act that you deal with regularly, and that is your discipline. The disciplinary actions aren't subject to this act, so that's why you have those in closed session. And I will say that one thing that has changed with the pandemic is the virtual meetings. So the governor has issued and issued back in March a proclamation, and it's been extended. Now it's extended through December 7th, but they've been extending it every month, so every 30 days, which it suspended certain parts of the Open Public Meetings Act, which allowed you to have virtual meetings without having to have a physical location. So that'll probably go on for many more months, that the governor says we have to meet virtually or telephonically. But some of those have been suspended, some of those requirements. So that has allowed a lot of flexibility for your meetings and other government agencies. So that's really all I had. I just wanted to give a quick refresher. There's like a one-pager sort of high points in your packet. I also included some resources on email exchange. This is from a local government group that has some nice handouts. So you can take a look at those. And then there's one slide on the proclamation as well. So if you have any questions, I'd be happy to answer them. If not, that's it.
And assuming the silence means there are no questions, I'm trying to find the unmute button. Okay. The next item on the agenda are the meeting dates for 2023. Amelia, is this something we have to formally adopt today?
Correct.
Okay. So it's on your screen. Anybody have an objection to any of those dates?
I make a motion that we approve them. Sorry, I make a motion that we approve them, especially since I won't be there.
Good for you, Teresa. Do we have a second? We have a second from Dr. Trescott. All in favor of the 2023 meeting dates, raise your hand or say aye, or both. Aye. Opposed? The meeting dates are adopted. Next item on the agenda is committee work group reports. The written reports are found on page 16. Are there any additions to the work group reports or any emphasis needed by anyone who wrote the work group reports?
This is Micah. So
Okay,
with
Micah.
respect to the telemedicine work group, I will say that we had a very good educational presentation. It was recorded, and I strongly encourage anyone who is interested, but especially those sitting on the telemedicine work group, to go and watch it. Dr. Scott did a great sort of an overview of telehealth, telemedicine in this state, and 98.6 was gracious enough to show us how their platform and AI works with real-time messaging and that sort of thing. So I think it's something that we didn't have very many commissioners on, so I encourage you all to watch it just to help you make an informed decision on your rules.
Thank you for that. I didn't have a chance to attend, but I did keep the documents. I'm going to watch it next week. Any other comments?
Michael, where is it located?
You know, Alden, the last WMC meeting document, there's a link in that.
Okay, that'll work. Thanks.
Micah, maybe we could have it sent out again, the link.
I can do that.
Great.
Thank you.
Thank you.
Next item on the agenda are rulemaking activities. Amelia?
So there's nothing more than what's on the progress report, except that we did finalize and file our rules for the physician chapter, and they should be effective November 21st.
Any questions for Amelia? Next is lists and labels. Heather?
Yeah, so you've got one request, and it's from the Optometric Physicians of Washington, and it would appear that they meet the requirement of being a professional association. So I would recommend approval.
Do we have a motion? Dr. Murphy, a second? Dr. Trescott, all in favor of adopting, or all in favor of allowing lists and labels for whoever they are, the Optometric Physicians of Washington group, say aye or raise your hand. Opposed? Approved. Public comment is next on the agenda. I want to read the public comment script. We will now begin the portion of the business meeting to take public comment. The purpose is to allow members of the public to directly address the commission on issues of public concern. Please refrain from providing comments on pending or open investigations or disciplinary cases. We will not be answering questions or responding. Staff will be available after the meeting to answer your questions. Please understand that although the time period for comment during the business meeting is limited, the public can attend and provide comment at commission committee meetings. The public can also contact staff during normal business hours. We welcome written comments as well. Each commenter will have 2 minutes to speak. When you comment, please state your name and who you represent. Would anyone like to comment at this time?
So it doesn't look like there's any hands raised or any questions in the question box.
Thank you. This concludes the public comment portion of the meeting.
Uh-oh. Uh-oh. Lost sound. You may need to unmute yourself. What has happened? Hold please. Mute all participants.
Oh, I'm back.
There we go.
Somebody muted me.
Sorry about that.
That's quite all right. I guess you got a little tired of listening to me. So I'll read the last sentence. I think that's probably wasn't heard. Again, you may provide written comments at any time. Next on the agenda is the Policy Committee report. I don't see Dr. Domino, but I assume she's somewhere. There you are. Thank you, Dr. Domino.
Thank you.
Sorry about that.
Yeah, sorry, I got muted. Let me just get rid of this thing. Oh, I don't want to close that out. So anyway, good morning, everybody. There are a couple items we're going to be discussing. The first one is on pages 29 to 36 in your packet. And these were two different previous guidelines that were updated. The first one is there on the left-hand side of the screen, communicating diagnostic test results to patients. This is one we had brought to you before, and one of the commissioners said, gee, this looks very similar to another guideline that was approved in 2018, which is on the right side, called direct communication of time-critical medical patient information between healthcare practitioners. Mike Farrell also tried to put these two things into one document because the commissioner recommended that. However, there is an essential difference between the documents. The one on the left, communicating diagnostic test results, goes to patients. It's the practitioner to the patient. Whereas the one on the right, the direct communication of critical patient information, is between healthcare practitioners. And because of the confusion of the words passing the baton, I certainly, and many of us on the policy committee, had no idea what that meant. We thought it was better to explicitly mention healthcare practitioners. So you can see in the documents, these were emailed out yesterday at 4:50 by Mike Farrell. The policy committee approved these changes, and so I wonder if there's any discussion from the commissioners. No discussion?
Dr. Yu has her hand up.
Oh, sorry, I can't see her. So please call on her, John, if you can see her in the thing. I'm afraid to minimize my screen because I may shut it off.
Okay. Dr. Yu? I think your telephone seems to be muted.
While she's unmuting, does anyone else have any? Yes, Dr. Small. We can't hear you either.
No. Dr. Wands has his hand up as well. You want to start?
Yeah, if someone's off of the mute, a lot of us got muted a little earlier, not by our own accord.
John, I was just signaling to Bob that couldn't hear him. Sorry.
Okay.
Oh, okay.
I don't know if you want to type it in the chat if we can't hear you. Mike Farrell said, Amelia, everyone may be muted because, yeah, just suddenly he muted all of us.
Right, I unmuted everyone, but it doesn't seem to be working. For Dr. Small, it says, hold please. It says attendee, it says click to send their PIN. So I don't know why it won't let me unmute him.
Well, John, I don't know what you want to do. If you want to just come back to it,
or because this may take a few minutes to go through, we can move on to the second issue.
Let me ask Dr. Yu if she's connected. Apparently she is not. Okay, well, let's go on to the next item and then we can come back.
Okay. The second item was an informational item, and this was on page 37. It was called the WAC 246-919-SXX Clinical Experience for the Limited License. This was an informational item related to the rulemaking that has been approved for international medical graduates. You saw on the previous slide that Amelia presented, or previous session that Amelia presented, that this is approved. The materials in here, we received comment from the Washington State Medical representative of the Washington State Medical Association, and it will be going to rule making, in which a lot of the things will be sorted out, and it's fairly descriptive. It lacks a lot of details. One of the salient things is that that these individuals do need to have proof of current Washington state residency for at least 2 years, and it's aimed at international medical graduates who are living and have been living in the state of Washington. And the Washington State Medical Association had a few comments about needs for direct supervision of these international medical graduates, alignment and specialty training, and then there needs to be sorted out about medical malpractice implications. I think there's a lot here that we don't really know what's happening, and it will be going to rulemaking. So it was just kind of presented for that. There is a slide, I think, that Mika, maybe you can make a few comments. There's a slide I saw yesterday that allows you to give comments to the work group. And I don't know specifically who is on this group, the rulemaking group.
So yes, there's the slide. If there are comments about the clinical experience rule, proposed rule language, you can send it to medical.rules@wmc.wa.gov. At this point, I don't believe that there is a rulemaking panel assembled. So if you would like to volunteer yourself to Mr. Malden, then you certainly can participate in this. There will be, just as an FYI, there will be more than just this rule coming forward. The Senate Bill 6551 required us to do rulemaking on a couple of fronts. This is just the first one. The next will be a clinical assessment tool recommendation from the IMG work group. And then there will also be an exceptional qualifications licensure waiver for rulemaking. So, and I believe we're looking through the rule groups and work groups, and I'm sorry, there is a few people there, mostly staff. So yeah, we need to fill it out for the rulemaking on the IMG licensing. So we currently need a public member at the very minimum and a chair at the very minimum, and then I'm sure we can get more folks on there. So just to give everyone the concept, the Senate Bill 6551 reestablished the International Medical Graduate Work Group, and they are tasked with considering certain things and making recommendations and reports to the legislature, but they're also tasked with making recommendations directly to the commission, so the commission can take it up and do any action that's required. So this is at very least is going to be a 5-year process. That's what the law requires currently at this point. And with that, I'll open it up for any other questions.
I just had one comment for plea for those of you who do participate in the training of medical students and residents. I think your expertise is particularly useful in this regard. It is just, I mean, I work in a university center, and we do have a lot of excellent internationally trained physicians in our center, and also in residency programs and in training programs. And the one comment I also wanted to mention is that they will be essentially like a medical student sort of position, and the ultimate goal is that they will develop enough clinical experience, which is very, very challenging for those who come to the U.S. often as a spouse of people in the tech industry, who come to the U.S. and they can't get any local clinical experience. And this will give them that sort of experience to allow them to therefore apply for residency programs, because residency programs will not generally not accept folks who don't have U.S. Clinical experience anywhere in the U.S., even as an observer. Any other comments?
Let's go back to item number 1 if there are no comments about this document.
Oh,
okay.
we see a hand up, sorry.
Oh.
Yeah, Jimmy Anderson here. So can we go back and look at the document, the side-by-side, document that we decided couldn't be merged?
We can do that, Jim, but let's make sure there are no other comments on the last
Certainly.
item. Okay. Your turn, Jim.
Okay, in the housekeeping category, the document on the right, it describes the focus group as being communication between healthcare practitioners. And in the introduction, with the ABCD section, it says encourage physician communication. And I think it would be good to make that consistent with the title, to make that encourage practitioner communication. I don't know if there are other, I can't see the rest, and I'm on the policy committee, but I couldn't make it yesterday. But I can't see below that right now. But if there are other uses of the word physician, I would encourage us to change that to practitioner to be consistent with the title. Thank you.
Yeah, thanks for bringing that up. We were trying to change things to healthcare practitioners, and that was just, I believe, an oversight in that.
Great, thank you.
Any other comments for those who were on mute before?
Dr. Yu has her hand up.
Yes. Can you comment? Sorry, now I can see you. Still can't hear you.
Still muted.
You might put it in the chat so we have your comment. While she's trying, who else was?
Mr. Farrell?
Yes, to go back to Jim's suggestion about using the word practitioners, I looked through this document, and if you look at the first page, the third paragraph beginning with the Washington Medical Commission, this document distinguishes at several points between clinicians and consultants and interpreting physicians. If you look at the fourth paragraph, it uses the term clinicians and interpreting physicians. So it took pains to distinguish between different types of physicians to make it clear. If you insert the word practitioners, you're going to be merging them all together. So, which is fine. I can redraft the document to merge them all together to practitioners, but I wonder if you're going to be losing some of this important distinctions.
Anyone have a comment about that?
Hey, Mike, this is Jim, and yeah, I hear you about that. So whatever you think makes the most sense. I just sometimes when I look at documents like this, and I know that we're supposedly directing them to PAs and physicians, that sometimes if I read encourage physician communication, I just think that seems to me to exclude PAs. But
I mean, that section could be healthcare practitioner communication. Maybe some of the ones later on, interpreting physicians. I don't know. Do you want to send it? Oh, Dr. Curry, see you.
I'll just comment that when I read this, I actually was a little bit confused about what interpreting physician or clinician was and what consultant was, because, you know, depending on your specialty, sometimes you're the referring kind of primary care person, sometimes you're the consultant. It doesn't, like in my world at least, those terms didn't really make a lot of sense, but I didn't think it was worth mentioning, except for now maybe it is, in light of the wording that we're trying to go for.
So, John, do you want to just bring that one back and try to just approve the other one about communicating diagnostic test results to patients? Or bring them both back?
Well, I think, well, do we have other comments on the first document, or any comments at all, I should say?
So this is Alden. I'm sorry, Richard had his hand up.
Alden, I defer to you, then I'll go after you. Thank you.
I'm willing to work with Mike on this to try and do some wordsmithing and see if we can make it a little bit clearer or whatever. If we want to bring it back, I would be happy to do that. I think this is a really important document, and I think it's really important to get it right.
Let's say you're on.
I just have a question about HIPAA compliance and how that is embedded in these documents. Could you just outline how the providers, the practitioners, or whoever is going to communicate with patients, if it's not in person, is protected from a HIPAA violation?
And you're asking me?
Yes.
I'm going to have trouble answering that off the top of my head, Dr. Wands. I'm going to have to think about that.
Okay, John, what would you like to? Oh, sorry.
How the physician would communicate with a patient and be HIPAA compliant?
Yes.
Yeah, that's an evolving area of law. If you want me to put more detail in this, I can, or I can talk to you offline after I do a little bit of research.
Whatever you'd like, Mike. I think it is important. It is evolving, but with more and more communications being done, not in person, either virtually or telephonically or by email, I think we need to have some clarity to protect practitioners from inadvertent HIPAA non-compliance, which could get them into legal problems. So we could talk offline if you'd like, no problem.
Richard, this is Alden. I have a bit of an issue with that, and that is that those aren't our laws, and we have to be really careful about interpreting them. And I think what we need to do is to say, you got to be careful, and there are traps, but I think if we try to get specific, they're not our laws, and we don't actually even enforce them.
The one comment I have is I think we should take it back, because I do know from the telemedicine communications that I receive from the University of Washington Medicine, that having other folks in the room when during these telemedicine visits is potentially an issue in terms of the family members and who's in the background of the telemedicine. And there's a whole bunch of emerging ways of dealing with it. So maybe we do need a couple sentences about it, not to provide direct guidance, but just to have something there. So does that seem reasonable? There are a lot of discussion items on both of these. So
Karen, I agree with that.
Yeah, I think we'll take it back. We'll rethink about it. If any of you have, like Dr. Wone, some particular comments about it, it would be very useful to provide them so that we can hopefully approve this in January.
Yeah, yeah, you know, the HIPAA issue is a difficult one. I asked a question when I was meeting with the HCA people because they kept talking about telemedicine, telehealth needing to be HIPAA compliant. And I said, how do you know? How do you know who's in the room with the patient? How do you know who's in the room with the physician? I said, well, we don't. So I don't know how you enforce it other than you make the generalized comment, I guess, in the policy that it needs, that your discussions should be HIPAA compliant.
So Dr. Small has added that HIPAA permits disclosures of healthcare information between healthcare practitioners for treatment purposes without patient consent.
I think we were talking primarily over the communicating diagnostic test results to patients. Is what I thought a lot of it, because relating to the telemedicine issue of other folks may be present.
I think that's right.
To be able to, it's something the provider needs to talk to them about, from what my limited understanding of it.
So it sounds like we need to defer both documents to our next meeting, correct?
Yes.
So we don't need a motion. We don't need to do anything else. We'll just wait till next time.
And please do submit your comments to Dr. Molden or myself about this, so we can try to improve this and get this passed. Thank you.
Amelia, do we have any chat stuff? I know Dr. Yu was typing at one point in time.
So just that comment from Dr. Small so far. Everything else is about them not being able to unmute themselves.
Okay. Next on the agenda are commissioner reports. Anybody have a report to make? Feel free to jump in.
Looks like Teresa has her hand up.
Oh, Teresa.
I'm going to do a newsletter article on teaching residents and physician students and medical students for the upcoming newsletter. And I would love to have any of you that have any thoughts about teaching and educating during this time of COVID to send me some input. I'm going to also ask my education committee at my hospital. But if any of you that do teach or take students have any input on some of the benefits, risks, how about if I just say risk, benefits, side effects, and alternatives for teaching during COVID-19? I would really appreciate the input into my article. Thank you.
I'll talk with you, Teresa, because we just did gave a telehealth conference, grand rounds on lots of aspects of telehealth, but one of the big parts was graduate medical education and medical students and how to incorporate that. So we should talk.
Oh yeah, absolutely. Thank you.
Other commissioner reports? Hearing none, we'll move on to staff reports. The written reports are found on page 53. Are there any additions or updates that need to be mentioned today by staff? Micah?
Yes, I would like to.
Oh. Who
Who
wants to
this
go
was
first?
Melanie.
Melanie, you go first.
Yes, thank you. I just wanted to say that this is the last official meeting of the commission for 2020. And I want to extend my appreciation and thanks to the commissioners and staff for bearing with us as we basically packed up everything regarding our processes and took them home with us. I still noticed that we have some issues with virtual meetings, and they're not perfect, but I appreciate your patience with the staff and with our processes as we tried to make them all electronic. I do want to give a shout out to my licensing unit that has completely gone paperless during the pandemic, working office every day to make sure that our licenses get renewed and our initial license applications are taking less time. So thank you very much for your understanding and patience. We are not having a retreat this year, but we will look into how we can update our strategic plan next year through maybe a virtual retreat, and we'll see how that works out. But thank you very much, and I appreciate your continued support for all of our virtualness. Thank you.
Thank you for those comments, Melanie. Micah, you had an item?
Dr. Roberts has his hand up.
Oh, sorry. Alden?
I just have a question about Morgan's report when we get to it. If Micah has something to say, let him go first.
Sure. So most of my stuff is written, but I just want to raise a couple of issues. The first is my recurring, please submit all your payroll and travel within 30 days. Rebecca King really appreciates it if you would do that. And then just a FYI, this will be my last day in the office for some months. I'm going on paternity leave. I should return sometime in April. So I've got a list of folks by issue area who you can contact. I'm going to highlight a couple of those. Stephanie Mason will be taking, she is our public information officer and legislative liaison. She will be taking the lead on legislative session in 2021. So if you have any constituent issues, you get contacted by a legislator or anything like that, please shoot her an email and get a hold of her. As far as the other items, I mentioned the Telemedicine Education Association. We want to give a great big thanks to Dr. Scott and 98.6 for their time, especially 98.6, because to have the regulator ask you to come and present your platform is an unusual request, and they were very gracious in going with it, and they saw some humor in it, so that was good. Finally, there's a demographic report in your packet. It's quite long, but it is the culmination of about 10 years worth of knowledge and work, and I want to highlight that so you all do to at least read the executive summary. I suggest you read all the way through it. There are recommendations from the staff who actually do this to you for the future of the demographic census. And so it would behoove you to read that and be familiar with the recommendations as they are coming forward. We are coming up next year on a time that we need to revamp the demographic census. That usually, as a process, will take about 6 to 8 months to hash out, because it's not just you that's changing the stuff. We have to go to innumerable stakeholders and get their feedback, ranging from the U to constituent groups to the legislators. And so I just want to highlight that. I also want to highlight the person who really put the lion's share of the work into that. His name is Nick Morris. He is a staffer who's been with us, by my recollection, I believe since 2013. He largely did that report on his own, and I just want to thank him for that. It's very well done, and just highlight him to you. And that's all I have.
Micah, it's Alden. For those of you who haven't read the demographic census or looked at it, it's got some really interesting information in it. It is absolutely worth looking at, especially if you have any interest in data at all. So I would also encourage everybody to look at it. It's very, very well done.
Thank you, Alden. Are there other adds or additions, Alden?
Yeah, I have a question about Morgan's report, and I don't know if Morgan's with us or not. But one of the things he says in his report, hang on one second until I can get it up here, is that he wants to make an effort to eliminate bias with the compliance packet, and it's been modified. That's in order to, as I recall, I got to make this big enough to where I can read it. And it's not responding. It's to eliminate bias. And since these are public meetings, and we see these people in person, we know whether they're male or female, we have to know what their names are. I don't quite understand what kind of modification we're getting ready to make, and it makes me a little bit concerned.
Right, so I'll just go ahead and say that these are going to be rolled out to the commissioners before they're made official. That's up front. That's always been the plan, but looking at what's going in the packets has been a challenge, and I'm not sure that we've even arrived on anything to recommend yet. The one thing that I can say is we have questions when someone goes, let's say, for a evaluation and something gets discovered that wasn't related to the complaint, say a family history of sexual abuse or something like that. Is that relevant? If it's not relevant to the actual practice of medicine and what the complaint was about, is that something that needs to be in the packet for the entire commission to see? Is that relevant to holding them in compliance? And so that's a conversation that we're wanting to have.
Well, that's great if we ever have that conversation.
Mm-hmm.
But there have been some changes related to bias, and I'm very much in favor of doing what we're doing. But there have been some changes that I think make our life difficult. And we don't have a discussion about it. It happens. Mm-hmm. I've voiced an objection to at least a couple of them, and there's been no discussion that goes beyond that, and everything persists. The big one that I have, and I've said it before, is when we're doing any sort of an assessment, we don't know whether the complainant is a physician, a nurse, a patient's mother, a patient, or whatever. And I'm sorry, that makes a difference to me. Mm-hmm. And I don't think that's bias.
Sure.
And I may be the only one, but the point is, if we're going to make a change, the commission has to have an opportunity to comment on those changes, and we're not getting it.
Mm-hmm. And I assure you, you absolutely will get the opportunity to comment on these changes. The other piece is I think we kind of universally agree that the compliance review sheet is a bit difficult to read. It's a lot of information, and it's kind of crammed in there in the form of I guess it's a Word document that probably could have been an Excel document, but we turned it into a PDF. And so that is one thing that we are looking at trying to improve for readability, at the very least, add a little white space.
Well, I would also like at the same time as offering a criticism, I would like to offer a compliment. And I think that what Panel L has done is dramatically great.
Okay.
In that situation, we don't know names, and we shouldn't know names. We don't know race, we don't see pictures, we don't see whether they're male or female. They've done an excellent job on that, because we don't need to know that stuff there. And so I want to make sure we don't throw the baby out with the bathwater here, but there are some things we need to know that have been deleted in some of the things that we've been asked to review.
Sure.
Do other staff have adds or amendments to their written reports? Sounds like it's a no by silence. Heather, you are on the agenda again for a AAG report. I don't know if you have anything else to add to what you said before, or another item, but
no, I have nothing. I have nothing else to add. Thank you.
Okay, didn't want to slight you at all. Anything else for the good of the order? Scott?
Thank you. And I don't want to reopen any previous discussion, very valid points. And I just wanted to say in the open meeting that the level and quality of the staff's work is incredible. I'm always astounded at the quality of the work and the amount of work that comes out of so few people. And I just want to echo, we're having this discussion in a public forum, and I think valid points were made. I just don't want to leave with any impression other than complete gratitude and thanks for truly an exceptional level, amount, and quality of work by the staff consistently.
Thank you for bringing that up and recognizing staff. I think everybody agrees that they do an unbelievable job. So thank you, staff, also. Any last comments? If not, we are adjourned. Next up, personal appearances. See you later. Bye.